I'm Stephen Silberstein, Professor of Neurology at Thomas Jefferson University and Director of the Jefferson Headache Center. I'm going to be talking about calcitonin gene-related peptide, CGRP, and the antibodies itself, and to CGRP and to the receptor. These are my conflicts of interest. Let's talk a bit about the immune system. Immunity is derived from the Latin word immunitas. It was protection from legal prosecution of Roman senators during their tenures in office, which meant if you committed a major crime in Rome, stay in office, they cannot prosecute you. Sound familiar? Function is defense against infectious microbes. A more inclusive definition is a reaction to components of microbes or macromolecules, which could be proteins, small chemicals, or polysaccharides. They're recognized as foreign regardless of the consequence, and even your own self-molecules may elicit an immune response. What is an antigen? It's a substance that evokes an immune response, or recognized by lymphocytes or by other antibodies. They're macromolecules, they're big, they're proteins and sugars, and usually foreign. They can be bound to the surface of a pathogen, or they can circulate freely. And the part of the antigen that's recognized by a lymphocyte is called a determinant or an epitope. An antibody is an immunoglobulin. There are two identical heavy chains connected to two identical light chains. It's Y-shaped. At the tip is where the antigen binds. At the bottom is where the antibody can bind to other cells to complement. An antibody is an immunoglobulin. It has two major regions, the antigen binding region, or the FAB region, and the FC region. An antigen has a part of it, which is called the epitope, that binds to the antibody, which is called the paratope. So you have the antibody, the antigen, and they bind. What's the difference between a polyclonal and a monoclonal antibody? Polyclonal antibodies are made from multiple B cells. They're different, and they recognize multiple antigens. A monoclonal antibody is made from a single B cell line and recognizes just one antigen and one part of the antigen called the epitope. Therapeutic monoclonal antibodies are all IgG. There are 4 types of IgG, 1, 2, 3, and 4, and in mice it's 1, 2A, 2B, and 3. They have a different ability to activate a host immune function, but what's really important, they can be genetically engineered to have them do what they want to do and what we want them to do. And Ig1 can kill cells directly, and if engineered, loses that ability. Ig2 and 4 are less effective of recruiting effector cells and complement, but again, they can disrupt target cell function. One of the points I make is, it's not the antibody that causes problems, it's what they do for a living that causes problems. And they can be engineered in such a manner that they have no interaction with the immune system. What's the convention for naming antibodies? The original antibodies were all mouse and were called OMAB. Then they're half mostly mouse, still a little bit, mostly human, 65%, and they were called ZMAB. Current antibodies are either humanized, which is over 90% protein, most of them are over 95%, and they're called ZUMAB. And the way I remember that is ZU for zoo, they contain non-human protein, and the 100% human protein antibodies are called UMAB. The people who make the nomenclature now does not recognize the difference between humanized and human antibodies, and for all intents and purposes, they're not using ZUMAB or UMAB on all of the new antibodies, but the ones that already have the name, it won't be changed. How do they work? A natural antibody can target and destroy a foreign pathogen. A therapeutic antibody can destroy a target cell or alter the target cell function without cell destruction. They can bind to the receptor or the ligand, or they can actually interact with different cells by binding to the immune system effector cells through the bottom of the Y of the antibody, that's the Fc receptor. There's actually non-immune mediated mechanisms of action which are very important. They do not require activation of the host immune system, so you do not have to worry about all these crazy diseases or getting tuberculosis testing. The action works through binding the target, and that means that the ligand cannot interact with the target, or binding the receptor prevents the ligand from going to the receptor. In both cases, they neutralize it. So it can neutralize the target ligands by binding to it, or it binds to the receptor and prevents the ligand from going to it. Antibodies can still interact with the immune system, and they do that through the bottom of the Y. This is called the Fc part of the receptor. It interacts with the Fc part of the antibody. It interacts with its own receptors, can actually kill cells or activate the complement system to produce cytotoxicity. When you hear about all the problems with antibodies, this is probably how they happen. What's important about antibodies and different from small molecules, they have to be given parenterally. They're big. They can't diffuse out of the stomach. They're denatured in the stomach and degraded. If you give it intravenously, you get rapid delivery. If you give it subcutaneous or IM, it's absorbed by the lymphatic system, dumped through the thoracic duct, and it takes up to a week to reach maximum concentrations. And antibodies are largely confined to the vasculature and in general do not pass the blood-brain barrier. They're safe. But in general, why do we get toxicity? What's the target? So let's say, for example, the target is some part of the defense system against microbes. It can make you more successful, more susceptible to that. If it's related to the host, the body can make antibodies to the antibody called anti-drug antibodies, which will neutralize them. So, most adverse events are related to the target. There can be the intended tissue or an unintended tissue which looks like the same to the antibody, or there's non-specific toxicities which are antibodies against the antibody itself. Now, what are the benefits of antibodies? Since they break down to amino acids, they have no toxic metabolites. You do not have to worry about drug interactions. They have a long half-life, which means they hang around for a month and they can be given infrequently. There's no off-target toxicity, and they're typically very tolerable. So let's compare a small molecule to an antibody. Small molecules are small, antibodies are big. Small molecules can be given orally. Antibodies need to be injected. Small molecules get into the brain. The monoclonal antibodies cannot pass the blood-brain barrier. Small molecules have half-lives of minutes to hours at most days. Monoclonal antibodies, typically about a month. Small molecules are made by chemists. Monoclonal antibodies have to be made in tissue culture. That's the contrast. In summary, therapeutic monoclonal antibodies are highly specific to a single target. They alter target cell function through non-immune system mechanisms. The safety includes target-related toxicities, which depends on the target, and off-target toxicities, so-called immunogenicity, where the body makes antibodies to the monoclonal antibody. There's a very low potential for drug-drug interactions, minimal central nervous system distribution, and a long half-life allows for dosing intervals ranging from days to weeks to even months. There are now 4 different monoclonal antibodies either on the market or in development for migraine prevention. There's one antibody, arenumab, which targets the canonical CGRP receptor. The other 3 antibodies target CGRP itself. The older drug, Episodic, targets CGRP. Erenumab from Amgen, Aimovig, targets the canonical CGRP receptor. The Teva drug, Fremanzumab or Ajovy, targets CGRP, and the Lilly drug, Galcanezumab or Emgality, also targets CGRP. So basically, there are two major classes of antibodies in this field. One that targets the receptor, and three that target CGRP itself. The first I want to talk about is Episodic, and this will be in alphabetical order. It's antibody against CGRP. What's also unique and different about it is that all the other antibodies are made in tissue culture. This uses a new way of making it. It's made in yeast. It's similar to all of the other antibodies in terms of efficacy. It's been genetically engineered, has a half-life of about 30 days, and when given intravenously, it works very quickly and has a bioavailability of 100%. If we look at one of the endpoints in the clinical trials, 75% in reduction in migraine days, it's achieved by a third of the chronic migraine patients by week 12. So you see the 50% response rate is over 50%. The primary endpoint in the trials was 75%. And you see, depending on the dose, it runs around 30 to 31%. So what we can tell our patients is that it's about 50 to 60% chance of having a 50% reduction. And if you have a 50% reduction, there's about 1 chance in 2 of having a 75% reduction. So after a single IV administration, we saw 75% response rates. In a post hoc analysis, the response occurs as early as 1 day after infusion. The response is maintained, severe migraine attacks were decreased, and so far in the clinical trials, no serious infusion reactions or treatment-related adverse events. Erenumab is a monoclonal antibody against the CGRP receptor, the canonical CGRP receptor, not the amylin receptor, genetically engineered and exquisitely sensitive for the CGRP receptor complex. This was a trial for the New England Journal of Medicine, showing the fact that both doses of Erenumab, 70 and 140 milligrams, separated quite early from placebo, and a statistically significant difference from placebo by month 1. So what were the conclusions in the episodic migraine study? Patients who got either 70 or 140 milligrams got relief. In whatever measure we looked at, migraine days, monthly migraine days, acute medication use, a significant concentration response relationship was observed with a greater reduction in migraine days at higher Erenumab concentrations. The adverse events and serious adverse events were similar to Erenumab and placebo. And this study showed evidence that anti-CGRP receptor monoclonal antibody is effective for migraine prevention with a safety profile similar to placebo. The next study was the same medication, and this was a preventative treatment of chronic migraine. Chronic migraine differs from episodic migraine in the fact that the patients have 15 or more headache days per month. This was published in the Lancet Neurology, and I was one of the authors. And basically, if you look at chronic migraine, you look at 50% reduction, you're seeing a rate of approximately 40% in both doses of Erenumab and about 23.5 compared to placebo. The conclusions were both doses worked, both had a significant improvement in 50% responder rates, and they were safe and tolerable, and the adverse events were similar to placebo. Again, showing that Erenumab is effective in migraine prevention in chronic migraine. The next antibody I'm going to be talking about is Fremanzumab. It is an anti-CGRP monoclonal antibody targeting CGRP itself. It's a humanized antibody. One of the differences between it and the other antibodies It can be given either monthly or quarterly, and there are 2 positive phase 2 trials and chronic migraine trials at different dosages. The first study I was the lead author on, published in the New England Journal of Medicine in November the 30th, 2017. And essentially what we found is there were a reduction in headache days with rifampicin compared to placebo. There was consequently reduction in migraine days compared to placebo. And basically the quarterly and the monthly followed each other with a slightly greater improvement that was not statistically significant in the monthly compared to the quarterly dose. If you look at the responder rate for 50% reduction, in this study it was close to 40% in both groups and about 18% in placebo. We can conclude that it was effective and statistically superior to placebo when given monthly or quarterly, and there are no significant treatment-related AEs, and there's very low discontinuation secondary to placebo. In particular, there's no difference between placebo and active arms. Following the publication of the chronic study, there was the episodic study, which was published in JAMA. Dr. Dodik was the senior author, I was the second author. And essentially what we showed that it was effective in episodic migraine, and basically looked at for week 8 and week 12, we found that if you looked at the quarterly and monthly, it was close to 50%. If you looked at the placebo, it was close to 30%, and these were patients who had a greater than 50% improvement. So we included the patient with episodic migraine who had not previously failed multiple medications, did quite well, and a statistically significant benefit compared to patients who received placebo. The last antibody in alphabetical order is galcanezumab. It's the Lilly antibody. It's an Ig4 monoclonal antibody. And basically, it was screened, optimized, and genetically engineered. And the trials include episodic, Evolve 1 and 2, and chronic, the Regain trial, and I'll show you the data. The episodic migraine phase 3 study was called Evolve, and looking at the 50, 75, and 100% response rates, you're seeing that both doses were effective and significant compared to placebo, with both 75 and 100% response rates showing the same. If you look at the chronic migraine, looking at the 50 and the 75%, you see for the 50% reduction, both doses were superior to placebo. And if you looked at the patients who received the 75% reduction, you see that the 240 milligrams was superior to placebo, whereas the lower dose didn't meet that criteria. We concluded that for the episodic trial, both doses met the primary and secondary endpoints. The treatment results were similar for efficacy, tolerability, and safety. With the chronic trial, both doses were superior to placebo in monthly mean migraine headache days and greater than 50% reduction in monthly mean migraine headache days. Low AEs, not clinically significant differences from placebo in any safety parameter. So let's take a look at all of the drugs together. If you look at episodic or enumab, galcanezumab, or rifampicin, the differences are really mainly a function of the placebo response rate. So the highest results have the highest placebo response rate, but if you subtract the result 56 minus 37, 50 minus 27, 61 minus 39, the therapeutic gain of the difference seems more similar than different. And if you look at the episodic migraine, the 75% responder rate, the highest is 62, but the 39 is what the placebo response was. If you look at the lowest, it was 48, but again, the placebo response rate was 28, with 20-point difference. So again, they're more closely similar than different. If you look at the chronic migraine response rates for episodic or enumab, galcanezumab, again, the major difference is the function of the placebo response rate. I want to remind you that apinzumab is given intravenously and has the highest placebo response rates. Now, one of the interesting studies that was done is the effect of erenumab in patients with stable angina. We know that during myocardial ischemia, the cardiac sensory nerves release vasodilatory mediators, including substance P, nitric oxide, and CGRP. It hypothesized that blocking CGRP may make things worse. So a study was actually designed to see whether erenumab impairs stress-induced myocardial ischemia in patients with stable angina. So what they did is they screened the patients, they did a baseline cardiac stress test, and the patients either got IV placebo or IV erenumab, and they were then put and given a stress test. And they looked at the following exercise duration, 3 to 12 minutes, and they wanted to see if the patient developed angina or ST segment depression. And they concluded that there was absolutely no difference in exercise capacity, a surrogate of underlying myocardial ischemia, and compared to placebo, no change in baseline from total exercise, no difference in the onset of 1 millimeter ST depression, no difference to angina, and no difference in AEs, supporting in this population of patients with stable angina that CGRP receptor blockade does not aggravate myocardial ischemia. If we take a look at the safety and the tolerability of all the antibodies, whether they're given monthly or quarterly, they're similar to placebo. Constipation seems more common with erenumab, about 3% at most. Hypersensitive reactions have been reported rarely for 2 of the drugs. Anti-drug antibodies did not appear to affect concentrations, efficacy, or adverse events, and there's been no interaction with oral contraceptives in the erenumab study. Long-term safety, there are now long-term extensions of erenumab for 3.2 going for 4 years. The most frequent adverse events were upper respiratory infections, sinusitis, influenza, and back pain. Remember, it's open-labeled, probably was no higher than placebo. There were serious adverse events at a rate of 4.2 per 100 patient years. 1 death occurred. This is really confounded by comorbidities. And there was no significant change, blood pressure, heart rate, or increase of cardiovascular events over time. So what can we conclude? They're effective. The onset is usually rapid within the first week. But just as important, if you don't respond immediately, you can respond later, 3 months later. So my suggestion is give the antibodies 3 to 6 months. They're safe. They're well tolerated. The major problem with injection site reactions. The long half-life supports infrequent dosing, and safety in pregnancy and lactation at this point in time are not known. Thank you.